Well, DVT is happening quite frequently as it's almost 100 in 100,000 persons per year incidence, and death rate is about 100,000 every year in the States. Um, this slide has been touched by one way or another by previous speakers, and we just what I want to highlight here is we have a lot of modalities has been started back in the 1930s, and cumulatively we just still using them but with a different sequence, with different priorities nowadays. So starting with the heparin in the 30s, and as well, fetal thrombectomy happened at that time. Afterward, the warfarin era and the TB and the plasmin injections systematically, filters in the 80s, and CDT at the 90s, mechanical thrombectomies endovascularly in the 2000, and then after the 2010, the purpose-designed venous stents and iliac dedicated even stents. So we basically in the venous era we learned the hard way uh, how I mean this disabling chronic post-thrombotic syndrome that is we're facing I mean, from time to time, and the management we do in chronic cases sometimes really falls apart. And this has been addressed clearly in this paper, which has been touched by Dr. Ahmed, the prognostic value classification done by him in July 2025. And basically, it's all about inflow issues, and this is why management in chronic diseases is falling apart due to this reason, as you can see from the graph. Just going to present a couple of cases. The first one is a 23-year-old lady. She's on oral contraceptives for 8 months, and she's been presented to a different institute, 2 weeks, history of pain, swelling in the left lower limb, and it was progressing. When we reached our center, it was 3 weeks plus history, and it's getting worse. So investigation showed that she has an iliofemoral DVT with Mathan syndrome and um, including, I mean, with a bad inflow characteristic. And the at that time the available was Cat 8 penumbra. So we've really sat and discussed her case. So we elected to do for her an open surgical thrombectomy. Um, so that's the dissection, and then over the wire embolectomy catheter went all the way down to below the knee, opening the inflow from the SFV popliteal as well as below-knee vessels, including profunda femoral vein. And then we went upward, embolectomy all the iliac veins, cleared up, and then stenting, ballooning, and then we have a good result afterwards. The second case is a 41-year-old gentleman, and he's presented with vague history of pelvic pain, right lower limb swelling, and raised creatinine. And he's known to have left kidney atrophy. Um, uh, he went through multiple investigations, and then lastly, we found him that having an iliocaval occlusion reaching the suprarenal segment with a large and congested kidneys. So this is the MRI without contrast has been done. I'm not sure if you can clearly see the iliocaval. So we sat with the patient and we discussed from him the complexity of his case and all the options and ups and downs of it and whatever we're feeling that is going to go ahead with. So they're really enthusiastic and really want to go ahead and intervene. So we just want to know what's going on there because it's not quite clear as we haven't done for him a CT, conventional CT venogram. So we did an angiogram showed this is the right common iliac vein showing really complete occlusion there and all going through collaterals. So we went through the right anterojugular vein venogram. We see that suprarenal is patent. So we deployed an IVC filter there. We tried to do, okay, past the thrombectomy catheter, we can progress really with it. So what we've done is We did snaring of the wire from jugular to the femoral, and then we passed the thrombectomy catheter over the wire to the lightning 12, and then, sorry, doing thrombectomy from there. We fished out subacute with acute thrombi from the area, and then we tried really hardly to pass the balloon. This was suprarenal. It is really squashed there, and this is probably his main problem was uh, venogram showed okay patent, but it's still quite shaggy. Uh, it was quite complex, and I do want really to finish up the management just in that session. So we elected to do for him a TBI infusion for 48 hours, and then taking him back at the cath lab, see what's happened. So after 2 days, take him back, angiogram showed okay, a better picture than the finishing one from the previous session. We as well cannulated the renal vein. We did thrombectomy from the renal vein, and then finished up with the stenting, the IVC, and ballooning. Patient discharged home, and eventually an apexaban, and he's for follow-up for IVC filter removal. So my conclusion, Mr. Chairman, ladies and gentlemen, is a venous occlusive disease is still undertreated in the acute setting, and still we are facing many indicated patients not being really intervened on initially. And many patients denied initial interventions when it's possible turn out to be a super complex in the subacute and or chronic phase. So we need to utilize the needed divesting modalities to improve success and longevity of treatment. Thank you.